Robotic prostatectomy, also known as the Da Vinci prostatectomy, has been available for about 8 years. Started in around 2002, but it really didn't become widely used until maybe 2005 or after that. We started doing robotic prostatectomies in 2003. It was shortly after the original report by a gentleman in Michigan issued his first 100 case study and reported his results, which we found astounding. Any man who has localized prostate cancer, who is a candidate for definitive surgery with intent to cure his prostate cancer, is a candidate for this operation. This is basically a cancer surgery for removal of the entire prostate for a cancer that is presumably confined to the prostate gland. It's the same surgery we did for many years before, but with the use of the robot, we can do it with minimally invasive technique and with a lot more precision. Precision is the key to the whole deal. And minimally invasive makes it easier for patients who are going through the surgery. The precision makes it better for them in the long run. When we started doing this in December of 2003, less than 15% of the prostatectomies in the U.S. were done robotically. Now in 2010, over 80% of the prostatectomies in the U.S. are done robotically. So you see, the tipping point was reached long ago, and this has now become widespread use. Some say standard of care. Instead of making a significantly lengthy incision, we make it through 5 or 6 poke holes in the abdomen. That causes less disturbance of the other abdominal tissues, less turmoil internally. And with the precision of the procedure, we have less blood loss. It's probably 20% of what the blood loss was on average with the traditional procedure. Patients are able to recover more rapidly. They have less time with a catheter. They're able to get up, walk, and start their diet sooner than they would with conventional surgery. All of those are big advantages for patients in the perioperative period. So it converts basically what used to be a stop sign into a speed bump. People can slow down, have the surgery, but get going faster rather than having to come to a complete stop, then restart their engines and get going 2 or 3 days later. Postoperatively, patients have shorter length of stay. Most of our patients are going home the day after surgery. They have shorter length until they can start resuming their diet and their usual activities. They have less time with a catheter, 1 week instead of 2 weeks. Typically have less pain medicine requirements. So they can fundamentally just resume a lot of their usual activities sooner than they would with conventional surgery. Plus, you know, with the lack of blood loss, with the lower amount of blood loss, they have more energy than they do if their blood tank, if their blood count's been drained. And so blood is oxygen carrying capability, and the more blood you have to carry oxygen in your system, the better your body will heal, and the faster you get your strength and your endurance back. So it all sort of is additive to their more rapid recovery. This whole robotic program is a team approach. It starts in my office, it carries through to the pre-op area, to the operating room, post-op area, and the nurses on the floor. Everybody has been familiarized enough with the procedure and what we're trying to do, and also been involved in the excitement of how well our patients are doing, that it's taken buy-in on the parts of the nurses, the anesthesiologists, the doctors, the operating room staff. Everybody has done a great job of trying to make this a really good program because it's created excitement. It's really generated a lot of enthusiasm by itself because of how well our patients are doing. And the patients always remain the center of everybody's focus. And that's a good attitude that's been permeated throughout this hospital. Having done the traditional surgery for over 20 years, and then when I did my first robotic case, and I walked out of that room, even though it took me a lot longer to do the first case than it does now, I knew right then that that was the way to treat my patients. There was no question in my mind. And even though at that time there was still controversy and there were a lot of people who were skeptics about this technology and about the application of it, it was very clear to me this was the best thing for my patients. I haven't looked back since, and the validation has been what I just mentioned, that now 80% of the prostatectomies are done this way. It's become de novo the standard of care. Again, the theme that permeates this Da Vinci technology is precision. And when you can do something with precision, that's what people consider to be surgical precision, and we're now able to do it. We can see better, we can do a better job of taking out the things that need to be taken out and leaving the things in that need to be left in. And that's what you consider to be surgical precision. We're now using the robot to do kidney surgery. We're basically able now to do, through minimally invasive technique, very complex kidney surgery that was previously extremely difficult to do except through open technique. We're doing some bladder surgery, we can do ureteral surgery, we do stone surgery for kidneys, we do a variety of things now. The technology can be applied to many different operations, and we're using that same precision technology to help us out with other types of procedures. I'm David Emmott. I'm a urologist at Shawnee Mission Medical Center, specializing in robotic surgery.